Buddy, let's get through the recording announcement first. Everybody got it? There we go. All right, welcome to our final session this afternoon for FDS Day 2. Thanks everybody for joining us. I am so very excited to hear this presentation. I was telling the team here that UMET gets to arm wrestle for who gets to cover which session, and I won this session, and I'm so excited for it. And I'm really glad that everybody could join us. From what I hear, it's going to be very active and interactive. And so I look forward to that as well. The title is Upstander Training. I love the title, and I'm going to turn it over to Dr. Huma Freed to introduce her team and then take it away. So welcome, team, and thank you so much.
Hello, everyone. Thank you so much for joining us. And thank you, Chris, for that very kind introduction. I am delighted to introduce myself. I am an OBGYN at the Beth Israel Deaconess Medical Center and the Associate Program Director for the OBGYN residency. And I have two fantastic collaborators who I've gotten to know really well in the course of our almost 2 years of doing this work together. I'm very lucky to call them colleagues and friends. Dr. Danielle Olvetsky, who is an internal medicine physician at the Beth Israel Deaconess Medical Center and our director for the DEI Council at Beth Israel Deaconess, and Dr. Cricket Fisher, who is internal medicine physician at the Brigham and Women's Hospital. Thank you to all of you for joining, and thanks to my two collaborators.
Amazing. Thank you as always, Huma. Thank you all for being here. We'll get ourselves started. We have nothing to disclose. And then we want to talk about how we're going to set up our space together. So I'll ask all of you to be present in whatever way you can. And we really honor that in all genuine senses. Like, my children are going to be coming home from school soon. Other children are probably making noise in other places. Like, who knows what time zone you're in? Maybe you're working out. Maybe you're folding laundry. Maybe you're like holding a loved one. We like you. We like you where you are. Turn your videos on and like be present for us if you can. No matter where you are. Bedhead and scrubs are all very welcome. We also want to say that we're aiming for productive discomfort in our time together. So in this little diagram in the center is the comfort zone. Nothing wrong with the comfort zone, but you might as well have just stayed and watched Netflix if you're going to be in the comfort zone the whole time. Out on the periphery is the danger zone. Also not where we want you to be. That is not a fruitful place for learning. We're aiming for somewhere in the middle. So titrating to get to that productive discomfort, which is a place of growth. We will assume, a little premature there. We'll assume the best intention of everybody who's come today, and we ask you to do that also, and to keep any individual experiences confidential while certainly sharing broader principles widely.
And so just a quick overview of our outline, the direction, the course we're going to take today. And it's such a pleasure to be here with you. We're going to spend a quick second on background, just to make sure we're all on the same page about what are we talking about and what are we addressing. And then we're going to spend a second internally reflecting on the barriers, because no matter how often we experience them, see them, witness them, they're super hard to respond to. I think it's good that we call ourselves into the space by acknowledging that communally. And then now we're going to leave you with a toolkit, which really was principally designed by Dr. Cricket Fisher. And it's just a wonderful resource where we can really learn to address these issues in a way that we find satisfactory. And then guess what, team? It's like being at the gym. We're going to practice. We're going to lift weights. So once you finish, you'll feel stronger, tougher, and ready to respond. And so just to make sure we're on the same page, we always show this slide, and this is because it's one of my heroes as well, Professor Chester Pierce, who was the first Black chair at Mass General in Boston, and he actually graduated from Harvard in the 1950s. So he coined the term of microaggressions, which says, that these are instances that are brief and common. They can be verbal, what we say to each other. They can be behavioral, whether we look somebody in the eye or we sit across the room from them. And they can be environmental, thinking about what's on our walls in our institutions. The main aim is that it's communicating a put down, that you don't belong here. You are less than. And it really occurs because of someone's marginalized status in society. And something that we really, really stress is that we all may have the best of intentions, but for this presentation and for this work we do, we really are thinking about, the impact. So it can be intentional or unintentional, but for this, we're thinking about the impact on the person who receives it.
And I wanted to share some quotes from a study that we had done in our OB/GYN department, asking faculty and trainees about their experiences with microaggressions.
And Dr. Fareed, would it be okay if we have people volunteer to read some quotes?
Yes.
All right, let's see some Zoom hands. Zoom hands are actually easier than actual hands because it lines you all up at the top of my screen. So let's see some hands here. You're going to read words that have already been offered by someone else. You do not have to generate your own words. You just have to be a good reader.
Oh, wow.
Or an adequate reader. Yes, volunteering. I love it. Yes,
Right.
Jane is there. Jane and I sat next to each other for a whole year at the AIDS Institute. So I'm excited to see her here and with her hand raised. Excellent. I love it. Keep them coming. Dr. Fareed, do you think two samples per person?
Yes, that'd be
Might
great.
need 3. We have 4 volunteers, so you could do 3 per person.
Mm-hmm.
All right,
We
here
have 5 volunteers.
Still
Yeah.
3 per person.
Yeah, 3 per person. Perfect.
Wonderful.
Chris, do you want to go first or?
Absolutely. Thank you. Thanks for the opportunity. Okay, here we go. After introducing myself as Dr. So-and-so and reviewing and counseling about results with patient and husband, they asked when the male doctor would be seeing them. My pay is lower than all men in my position with my years of experience. And supervising physician asked me why I work so hard as I'm married and my husband can take care of me.
All right, thank you. We'll go on to Jane, who's next on my screen.
As a female moving into leadership roles, I am often asked why I am present at meetings. Staff has addressed more junior staff who are male directly with questions or suggestions and bypassed me. Frequent comments about too young to be a surgeon from patients, or I was told I was too young to be in a leadership role.
Just want to take one moment. You know, I've read these multiple times, but each time it just makes me feel terrible. So I don't know how you all are feeling, but whatever you're feeling is okay. And I just want us to sit for a moment with these words from our, colleagues, essentially. Although many of you may not be in Boston, but these are colleagues who you're going to work with, colleagues who you share patients with, and these are what people are saying have been said to them. Veronica is the next on my screen.
If I am experienced enough to care for them, if I'm really the physician. Patients will ask how many of a particular procedure I have done. Pretty sure if a male MD were asking, there would be less eye roll and passive aggressive pushback. Minorities are questioned and challenged more than the non-minorities in the department by support staff.
Thank you. Go on to Emily.
Disrespectful language or name calling. Ignoring accomplishments or accolades. Dismissive of colleague input. Being called by the wrong name. A nurse has also told a patient in front of me that I have small Asian fingers, so my vaginal exams are more comfortable than from other providers.
Thank you. We'll go on to Sybil.
Over penalization for minor offenses. I've had nurses ask me to translate for them because they did not want to call the interpreter. Assumptions of being married to a person of the opposite sex.
And then we have 2 more remaining. Uma, I don't know if you want to read these.
I'll read it. Yep. Was asked by an attending when I was going to stop the whole pumping thing when I said I couldn't make lunch with everyone between back-to-back OR cases. I want to remind us this is from an OB/GYN. Individuals voicing surprise that someone like me can be a GYN surgeon, that I'm so articulate. Again, really hard phrases to hear, really hard things to grapple with, but these are all from our colleagues and from people who we share patients with and people who are just seeking to provide the best patient care that they can. So I want us to think seriously about how this impacts how we act as physicians and how we're able to function within the hospital. We did a study of OBGYN faculty and residents, and that's where these quotes came from. And then we analyzed some of the data and asked our faculty and trainees how often they experienced either microaggressions or overt discrimination, which, as we know from studies, overt discrimination is less common in medicine. But you can see that over half of people had ever experienced microaggressions and discrimination, and some of them, not an insignificant percentage, 15% almost, experienced microaggressions weekly, and a fewer amount experienced them daily. So this is pretty significant results of what happens within the hospital and how this is much more common than we may think that it is. And when people experience this, I'm the associate program director. I'd never heard any of these comments that people had written in the survey until we conducted the survey, because people may be reluctant to talk about them.
We have some studies that are looking at the impact of experiencing microaggressions. Notably, these are not RCTs, these are looking at associations. But individuals who have a higher burden of experiencing microaggressions are more likely to experience depression, anxiety, elicit a trauma response when exposed to new stressors. They have lower self-esteem, higher rates of burnout and suicidal ideation. And the burnout and suicidal ideation is from a cross-sectional study of 7,500 surgical residents. More likely to have feelings of isolation or mistrust, to report episodes of binge drinking, a hostile or invalidating work climate, and impaired productivity or problem solving. So basically the opposite of what we want from our healthcare institutions and our learning centers. That was our brief background into the land of microaggressions. And we're going to launch now into thinking about what are some of, how do we move into action and what are some of the barriers in our action. So for that, we're going to have you do a little poll everywhere exercise. You can send a text to Dr. Cricket. Send the text to phone number 37607. Content of the text should be Dr. Cricket. Or you can go online to pollev.com/Dr. Cricket. Either way, it'll hook you into my Poll Everywhere stream. When you get there, it'll be like, thank you for joining the Poll Everywhere stream. And now I'm going to ask you to think about a time when you experienced a microaggression as a target or a witness, and you didn't respond in a way that felt satisfactory to you. Why didn't you? Type a word or a couple of words about why you didn't respond. Yes, fear, we get to do this with all different kinds of providers of all specialties and all different levels of training. And there has not been a time without fear. Overreacting. I'm just going to let this populate for about 15 seconds and I'm going to start commenting. So we have our fear of retribution. That was kind of the first one that popped up. And we want to acknowledge that there's real risk involved in responding to a microaggression. And the fear can be a fear of jeopardizing a relationship, like a therapeutic relationship with a patient, fear of jeopardizing a productive relationship with a colleague, fear of job retribution or compromise. You need a letter, you want to be promoted, fear of personal safety. So we don't need to be walking into this with rose-tinted lenses saying everybody should just respond to microaggressions, it's fine. We're acknowledging that this is hard and there is real fear and there's risk involved. I see another one there, embarrassment. I love this one. There's so many different ways to interpret many of these words. And if I'm doing your word, if I'm not doing it justice, I hope that you'll raise your Zoom hand or unmute and share some more, clarify some more. That embarrassment can be like, I am embarrassed about what just happened and I don't want to worsen my embarrassment. It is embarrassing to consider speaking up to this microaggression, or I don't want in my response to make somebody else embarrassed, be that person who was responsible for the microaggression or a very nuanced and important dynamic. If I'm a witness, I want to make sure that my ability to stand up or be an upstander doesn't compromise somebody else's kind of autonomy and what they would want, doesn't step on their toes by me standing up. I can't go on without saying didn't know what to say. Like, I feel like that's being outlined right here in our word cloud, which is that even if we did get through all of these barriers, which include embarrassment, fear of overreacting, which also kind of gets into some stereotype threats, that I'm afraid I'm going to fulfill this stereotype of somebody who overreacts or is too emotional or hysterical or too sensitive, right? That stereotype threat will cause us to not act. Even if I'm willing to face the fear or the risk and the consequences, I might just not know what to say. And that these are so fraught because of the medical hierarchy, which is just laced with power. And I'll say one thing about the embarrassment and the awkwardness is that we are not taught to respond to microaggressions. Microaggressions, if I put on my sociologist hat for a little while, which was my career before I went into medicine, microaggressions are a way of perpetuating the status quo. It's a way of continuing to exert power by those who have power. And it's so hard and so awkward to respond because that's part of the message. We are taught to not respond. We're taught to swallow what we're experiencing, to efface the self in order to perpetuate the status quo and keep those who have power in power. So to acknowledge how hard and uncomfortable and scary that is, and that's part of the problem. And that's deliberate. Shy. Okay, fine. Maybe it's deliberate and part of the overall structure, but I'm just not a very confrontational person and I don't like doing that. And so that's particularly hard for me. Totally valid. And another factor that comes into play. Empathy. I love seeing that here, especially when thinking about barriers, which it might be that I empathize with the person who was responsible for the microaggression and I don't want to publicly shame them, or I want to be able to respond in a way that conveys my empathy. And again, I don't know how. Past. So these happen out of nowhere and in the middle of your day, right? It'd be one thing if you're we're going to go see a GP or G3P1 who has a history of microaggressions coming in with concern for preeclampsia, right? You'd be like, oh, okay, got my game face on, I'm ready. But no, they come out of nowhere and they blast us out of the space we were in, and then we can't think clinically. And meanwhile, the moment has passed where you might have responded and you need to go on with your day. Dr. Uletsky or Fareed, anything else you want to add to this slide before I go on? Has a history of microaggressions, right? Yeah, chronic offender. I don't know what to do with that. Okay, so here's a catch-all slide of some of the other things that we see in the literature about reasons for not responding. Stunned, we are thrown into our fight, flight, or freeze, and way out of our window of emotional tolerance, which is that space in which we can think and feel at the same time. And then you can't come up with any words because your reptilian brain has taken over. Sometimes they're ambiguous, right? Wouldn't it be great if all of our forms of bias came with a very clear label and that arrow sign on radiology being this is bias here? No, they're subtle and they're sneaky. And you have to be what was that about? Was that about me? Did they not like me? Is that because I'm a woman? Is that because I'm gay? Is that what's happening here? And having to tease that apart. There's fear and doubt. We address the fear, but the doubt, I don't think this is going to make a difference. So am I going to stick my neck out for all of that risk if it's not going to make a difference? Fatigue, bone tired, right? I can be physically tired. It's 26 of a 28-hour call, or I can be tired of all the microaggressions that have come before. We talked about preservation, some of this risk, benefit, and knowledge.
What we really want, one of the takeaways from this talk, and we really want to make it clear that, our silence is not neutral. Our silence is perpetuating that status quo. And especially us as faculty, it really is our role to role model for our trainees all around us and our patients, how we address this. Because for all the times that I faced a lot of racism, being called a nigger, hit, yelled at, etc., what I really remember is the silence. And it's hurtful to the person who experiences it. But into the bigger picture of what we wish for the future of medicine, it's pretty damning because we're preserving the status quo.
Okay, so great, fine, set the stage. How about some tools, please? Let's get into our toolkit.
Right now.
Okay, perfect. So Danielle's going to put an actual document into the chat, which is a toolkit that I've had the opportunity to develop over a number of years now with colleagues, including Drs. Uletsky and Fareed, and many other collaborators, with some strategies for how you can respond. This is a toolkit that's meant to be adapted and combined for you as needed to fit your situation. Can be used when you're the witness of a microaggression, when you're the target of a microaggression. And if you can, I know classic pedagogy, like faux pas, giving you a tool that you're like, I want to look at it and stop listening to you. But before you look at it, if you can listen to me for another slide, which is to say, I like to think, and we like to think of 3 things to help you decide how to pick a strategy. The first is fit. Strategy's got to fit you and it's got to fit the situation. We are all wildly different people, and these happen in innumerable different contexts. We need to have something that feels genuine and resonates. And so that's why it's nice to have a spectrum of responses. The goal when we respond to a microaggression can also be very different. If I'm interacting with somebody who I think is extremely well-intentioned and would be horrified if they knew the implications of what they had said, that's going to drive the kind of strategy that I choose to respond. If, however, I'm dealing with one of my patients who's in florid psychotic delirium and has no idea what's happening and will not remember it tomorrow, that's going to also tailor the kind of response that I want. And my goal might not be to change their mind at all, but be to affect the learner who's watching us, or the group of PCAs and nurses and environmental staff who have to weather this all the time. And then another goal might be, I want to feel less terrible. I actually don't need to prioritize how this person feels about how I feel, that I want to do something to stand up for that, like medical ethics principle of justice for myself. So recognizing that it's got to fit you, fit the situation, it's got to match your goal. And then there is no gold standard for saying this warranted a response, this didn't, this is a microaggression, this isn't, that response was good enough, that one wasn't. There's no arbiter. So we have come to land on, you just have to figure out if it felt satisfactory to you and all of the complex nuance within. Did you walk away from that feeling, okay, great, that strategy sounds like it works all right for you. But if you walk away from it and it's wearing on you and it continues to hurt and it continues to rub in the bad way, that's a sign that you maybe should try a different strategy next time. Okay, that's the preamble. Let's go through some strategies. So we'll each go through 5. You have your toolkit. We're going to breeze right through these, and then we're going to get into some small group cases. First 5 in not a overly particular order, but kind of in increasing increments of directness. The first is to prepare yourself and your team. You're doing some of that right now by doing this workshop. Another one is with your team to say, we're apt to encounter microaggressions in our time together. It really matters to me if that's happening. I hope that you'll talk about it with me. Or if this occurs, how would you like me to respond? Micro affirmations is in the face of somebody being put down, you build them back up again. You don't even have to directly engage with the material of the microaggression. It's just affirming that person. Somebody says, I don't want this person touching me. Oh, Provider X is one of our most exceptional members of the team. I would have her take care of my mother any day. Buying time. Oh my gosh, something just happened. My brain needs a chance to catch up. Maybe your brain needs a chance to catch up to figure out what you just said. I will insert some filler words to allow us to all get there. Something like, what? Or, okay. Or, I'm sorry, I didn't catch that. Could you say that again? Interrupt and redirect is a pivot move. It does not address like the overall impact of the microaggression. It just gets you out of there. You're like, we are no longer in what is safe and appropriate. So I will interrupt what's happening and say, so sorry to interrupt, but I think we need to move on to the patient in room 3. Or speaking of hypertension, like fall back on the things you always can fall back on. Interrupt and redirect. This marries well with a debrief afterwards, which Dr. Olvetsky will get to. And then using humor. This one's hard to script, but something that a lot of us go to with the danger of it becoming a little biting. But recognizing that it can also be a very helpful tool to lighten the mood. Like, lucky for you, I am old enough to be a doctor.
And then there are other strategies like reflecting back, sort of repeating exactly what you heard the person say so that when it comes out of your mouth, they have the opportunity to hear what they said and maybe reconsider what they've said. And, something just, I think I heard you say this. Is that what you meant? And sometimes people will backtrack and say, actually, no, that came out all wrong. But at least you've sort of given them a jolt and made them listen to what their words sounded like when said out loud. getting curious, inquiring about someone's perspective or intent with the sort of approach of open curiosity, saying, what made you say that? Or can you help me understand what you meant by that? So you're leaving it open. You're assuming best intentions, which is sort of the next response strategy. I think sometimes people may say something that they think is funny, or they're trying to make a joke and it is hurtful. And so I think you can say, I think you intended to be humorous or funny, but that comment really could also suggest that you're making fun of somebody. And I think stating your take, just saying how you feel, I think that's really powerful, because people may not understand or realize that this comment hurt you. And I think you can say, when I heard you talk about people like this, I felt sad because I identify as somebody who is like this. Or, I was so shocked by the remark that you just said that I really got thrown off. And that sort of invites them to accept responsibility and move forward. And then setting respectful boundaries. I think this is one that can be very challenging, but your goal is to set limits while saying, I still value the relationship that you and I have. And I think you could say something like, I really care about you as a person, but I can't listen to you talking about people like this. Or please, if it's to a patient, I think it's a little bit easier. Please don't make that type of comment. We're here just to take care of you, and let's focus on your medical issues.
Now, if things are really egregious, this number one is one that I actually truly do like a lot, because this is the rubber hitting the road. You're like, hold up now. And you can say, but then you don't become the bad guy. You say, while it's a privilege to care for you, I want to make sure you understand that your behavior is not consistent with the values of this institution. And that way is a way of like a hard stop. And then, of course, the next level from that at our place would be, we'll help you find care elsewhere. But at least it gives the patient, this is the line in the sand. Disengage if you feel unsafe. Please, always leave if you're not safe. And then another favorite one of mine is the debrief, because, gosh, as Cricket said, we all walk in, like, when I work nights, I know there's a chance that could be a code. So I'm walking in doing the code algorithms in my mind, but we're not really practicing for microaggressions all the time. So the debrief is great when you can go out with each team and say, I'm not sure I handled that well. What do you think? You can take each party aside. Revisit is similar to the debrief, where you can return like almost a week later if you've slept, gone for a run, talked about it with other people, and address it again. And then escalation, I think escalate kind of looks like a negative connotation here, but we all are moving towards really logging in these issues when they occur so we can track them. And then also calling upon the support of other people who may be less tired, less exhausted than we are, and can really give some overarching guidance and benefit. So the point is that you're never really alone.
All right, thank you all so much. Oh, I think Dr. Levesque will let you keep going with introducing our small group cases. And then you have a window before we go into our small groups, maybe you can redrop in the document just in case somebody joined in the interim so they have access to that.
Sure, I will. So this is a really important part, actually, maybe the part we were building up to in the talk is, how do we practice this? How do we really make this part of our makeup so we feel really comfortable doing it? Just like we learn to suture, we learn to listen to the heart sounds, it's the same thing. We just need to really build this into our repertoire. So we're going to have 3 cases. We'll try to spend 5 minutes per case. You can pick as though you're going to respond as though you were the target that it was directed at you, or you were a faculty member and you were a witness of your trainees or another faculty member. And now if I could take, if only I could highlight this reflex strategies, aspirational strategies, I would like put a circle around that. So the main aim of this is like, our reflex strategies can be like, for me, it used to be plain old anger. I used to just get mad. So after many years, I realized that our reflex strategy is kind of like maladaptive. And so as we grow and mature, as my daughter would say, as we have a growth mindset, we're really trying to get to our aspirational strategies. So what's an aspirational strategy? That's the one that when you do it, you wish you could have been videotaped. You want to show it to your grandkids. You were so cool. You were so ready. You like knocked it out of the park and you feel good about it. So the whole point is that we're trying to work from the reflex to the aspirational. Please identify one person to be your spokesperson at the end so we can share our experiences. And with that, I'm just going to go ahead and pop those cases into the chat for those of you who can't see it. Hopefully
we can probably, yeah, and you don't have to open the cases because we'll be in there in the room.
Oh, sorry.
but the toolkit, so that I think we just
Again,
had
oh,
some
yeah. Oh, right, lovely. No more, that is 2 seconds away as well. So
Thank you so much. Chris, are you ready on deck with our 3 smaller brooms? Perfect.
All right, everybody.
We are on time, which is just breathtaking.
Fly. Let's fly.
We'll come back at 5:10.
5:10. Okay, and I'm going to put everybody into breakouts, and then I may need to move around our facilitators a little bit. So bear with me, everybody, as you get your bearings. Here we go.
We'll wait, Chris.
Thank you so much, Chris. Really appreciate it.
One second, and this is going to be perfect. It actually did a pretty good job. Okay, here we go. Ready? And go.
Okay. So I should join the room that you assigned me to, right?
Yes. Yeah. Go to the room that it says, I think you're going to be good.
Always so abrupt.
I know.
Sorry about that. I wish there was a better way.
Oh my God, so many great conversations in our group. Thank you all for sharing and participating and using aspirational strategies.
Definitely.
So I'll start with my group. Rong, I think I kindly volunteered you to be our report out, but anyone feel free to jump in. There's not that many of us, and I think it'd be great to hear, like, what did you find that was hard about this, and what aspirational strategies did you most identify with?
I think our group focused a lot about on how hard it is sometimes to speak up because it is uncomfortable in the moment. And so because we're not confrontational, several of us. And so we focused on redirecting or stepping out of the situation and then addressing with our team afterwards.
Yeah, I think
aspirationally,
we
talked about, oh, sorry, I was going to say, we definitely talked about humor, about calling out people, and about trying to make sure that we debriefed with our trainees especially and made sure they knew that we valued what they were bringing and that we recognized what was going on and wanted to be better role models for them.
Thank you. And I think that was definitely a very strong undercurrent in our room of, maybe we're not going to be able to redirect the 80-year-old husband of our patient who's a survivor of ovarian cancer and maybe just doesn't know how to express his appreciation for us saving his wife's life, but is, thinking he's paying us a compliment. But I think checking in with the team and making sure everybody feels like they had the opportunity to debrief and process was definitely a theme in our room. Dr. Olvetsky, what was a theme in your room?
I think we had just 2 and we had wonderful discussions. I might actually call on both Isabel and also Veronica just to share 2 things. I think Isabel had a wonderful quote with the Asian family. And one was, do you remember when you said, how are we missing an opportunity? I thought that was great. Do you remember that, Isabel? You're like, what is she talking about?
Yeah, no. So the idea of kind of moving more to problem solving, because there's always going to be patients that we're frustrated with for one reason or another. So moving on from saying something like, wow, where is there an opportunity here that we might be missing to meet this patient's needs then? I understand it's frustrating. And this was to piggyback on Veronica's comment of like, we're trying to strive to provide the best care to all of our patients, no matter where they're from or kind of what beliefs they bring in the door. That's come up a lot with the elections and with COVID and all that kind of stuff. So I try to go to the next step usually and be kind of on the problem solving mode of like, okay, so where can we meet this patient? How can we move their care forward? Where are we missing the opportunity? What should we be doing better? Like, it's not about the patient, it's about us, finding a way to connect with this person and get their care moving.
And what I liked about what Veronica had said actually was when she said that, she used that whole thing of it's our mission to provide care of our patients no matter where they're from. Remember how you ended, Veronica? You said, so let's respect their.
Right, or like their beliefs about health.
Yeah, I thought that was really nice to mix those two things together. So we had a lot of mix and matching, kind of getting to that higher level, our North Star of providing excellent patient care and meeting patients where they are.
I think particularly true during this current pandemic when so many of our pregnant patients do not want to get vaccinated despite ACOG and SMFM guidelines encouraging them to do so. It's one of the hardest conversations I've been having in my career, I think. Yeah, so particularly true. Thank you for sharing. Dr. Fisher, your group.
Yeah, I was totally delinquent and failed to ask them to appoint a spokesperson. So we'll just do it on the fly. I don't
Perfect.
know, Emily, Sybil, or Chris, if you're willing to share out something that felt like a little gem of something salient or a little nugget that you're still thinking about.
Here, I talk a lot, and I'll introduce both Emily and Sybil's ideas because they were the best. Emily had mentioned that she had an experience where there was a pre-teen brief on how to respond to microaggressions as a student, and that this was wonderfully well received, and that some people said, no, don't worry, I got this. I've been responding to this my whole life, and I got my strategy, and other people were more, thank you, or I need an approach. And then Sybil's comment about the inappropriate patient, partner making comments about how good looking the team is just first, just walk out the door and not even give them the respect of a response. And we talked about how, though, you still carry that with you through the day, and that person's behavior is not changed, but is it your burden to have to stop in your tracks? You're busy and turn around and teach this person, and sort of that's at the hallmark of the microaggression, right?
Yeah, I think with that particular example, Cricket said it in a way that I really liked, and I think I'm going to take away from the session is like sometimes there is power in walking away, which, I like that. You don't necessarily always have to confront these things head on. I mean, hopefully, we have tools in our toolbox now to do that sometimes, but it doesn't have to be all the time.
And to add another layer of complication for that, because how do we understand that it's okay to sometimes just walk away with also knowing that our silence is not neutral? Because it's one thing when I'm the target, and it's another thing when I'm the witness. And also recognizing that I may be perceiving myself to be the target, but somebody else might see me as a witness, or like worsening, perpetrating this microaggression by not standing up, whereas I'm feeling threatened. And there is just so much that can be saved with a debrief. So knowing that our silence is not neutral doesn't mean that sometimes my response is silence, because it is all I can come up with. And that I can save that afterwards by saying, I was feeling a lot of feels in that moment, and I don't think I handled that great, but I'd love for us to be able to talk about that, or to revisit again.
Yeah, I think so powerful. Thank you, Cricket. I think so powerful, especially when we are educators and there's, students, trainees watching us. And I think back to the own experiences I had, and when a faculty member, stood up for me, and I still remember that incident, still remember how they did that as a witness. And I think it can be very powerful to role model for our trainees, but also to debrief. Like if you're unable to rise to the occasion, which I certainly have not done well, just saying, yeah, I really did not respond to that well. This person is a friend of mine, and I'm very sorry. Whatever she said was inappropriate. How do you feel? But I think debriefing, and that was a common theme in our room as well. Any other thoughts that people have before we move on?
I think I just appreciated Dr. Fisher's suggestions that, when we practice this over and over again, there are some things that can become reflexive. And even when it's, maybe not the best thing that could possibly come out of your mouth, or the strongest stance that you would want to make, just sometimes a reflexive curiosity or question like, what do you mean by that, is something that is possible to get out there even when you're still kind of reeling. And so that's something that I'll definitely take forward.
I feel like in our small group, we really focused on the theme of microaffirmations and how helpful that can be to people that are targets. And so just really remembering that, especially as we lead teams, as we're in charge of like the education programming, that we really can help uplift our students and staff and other colleagues who are victims of these incidents.
And we would be remiss if we didn't share strategies from one other kind of microaggression, which is when we are the ones responsible for microaggression. So I'll give a short example of, I'm a hospitalist, I'm a direct care provider. I go and I see the patients and the nurses, and I'm very dutiful. I round up my nurses, we chat about it. I go back, I'm writing notes. A day like this, I went back to see the patient, and there was a woman who I racialized as Black by the patient's room, who I hadn't seen earlier. And I was like, oh, are you the PCA for today? And she said, no, I'm the nurse. And how did I respond to that? So this is one that actually I'd be okay with filming and showing my grandchildren. I follow this format of pausing, apologizing, and my Jewish heritage teaches me that you have to acknowledge to make it a real apology. So I am sorry. I assumed that you were the PCA instead of the nurse, and that was an incorrect assumption. Thank you for correcting me. And then I moved on. I did not take this as an opportunity to defend my morality. Actually, I teach these microaggression response trainings, and I have Black friends, and I'm a good person. I didn't force her to be like, actually, no, because I rounded with the nurse already today, so I didn't realize that you had like shift change, because like I'm working at 12. So no, I didn't make this about me. This was about a time to apologize, acknowledge, thank, and then do the rest of the work on my own, because I do have to acknowledge my racism and the fact that I made a heuristic leap to PCA and not nurse or neurosurgery consultant. Like I made that leap, I have to own that, and it's not the time to put that back out there and make it about my feelings. So I recommend this rubric for when you are the one responsible. And note, we don't say if you are the one responsible, but when you are the one responsible, because we all have implicit biases and they all leak out. I think Dr. Ulvetsky, you get to close us out here.
Totally. I think what we really want you to focus on now is just kind of what others started gathering on, which is what is the one takeaway going to be from this? And I think of it as, we're going to hit that red leave button in just a few minutes, in 3 minutes. And when you hit that red leave button on the Zoom screen, what is one thing that you're going to be doing differently than when you came into the session about an hour ago? And that's what we mean by what's your one takeaway. And we really want you just to write it down, and we learn from each other. And the writing it down really commits us to saying, this is what I got out of this hour, and this is what I'm going to practice going forward.
I apologize that for the life of me, I can't make this font any bigger. I've tried many different incarnations of this, but we're seeing.
I'm going to put it in the chat again. It's coming right now. You should see it. Do you get it in the chat? Someone asked for it in the chat.
Oh, perfect. We're seeing practice, preparation, use the words, be brave. Our silence is not neutral.
Sorry, Dr. Fisher, are you seeing this coming up on your
screen? Are
you
not seeing my good stuff?
No, not at all, darling.
Let's try that again.
Sometimes you have to like just refresh the screen and it will pop up for us, but it's not coming up in real time.
There we go. How about now?
Yeah.
Still nothing?
Yeah, I do see it.
We're good. Okay.
Wonderful preparedness. Our silence is not neutral. Be brave. Yeah. I love the be brave, because I think that's kind of what we're called upon to do in these times, is to really, every day feels like we're going where no one has gone before sometimes in these times. So it's just really fitting. If we really want to disrupt the status quo, we just have to be brave, and knowing that our silence is not neutral.
And in our last few seconds, I just want to thank all of our participants. Thank you for showing up despite the changes in the conference. Thank you to Kelly, who I know is not on here, but she was immensely helpful in setting up all the Zooms and coordinating with us. And thanks to Chris and Kate for helping us run this session. We have many supporters at Brigham and Beth Israel Deaconess, without whom we could not have made this possible. So I wanted to take a moment to acknowledge all of them who have helped support us in our work and help contribute to the workshop development. Please feel free to reach out if you have any questions or if you have any suggestions for how to make this better. Thank you so much again for being here and participating.
I got the request, by the way, to send out the toolkit by email, and I'm happy to put in my email.
Thank you. It's just so good that it'd be really helpful. A group of us are leading a session on the 28th on like how to actually do this training with residents and stuff. And this toolkit's really lovely for some concrete examples for people. So really awesome.
So Dr. Fisher and Dr. Freed, thank you for a great presentation. Thank you for that toolkit. And from the bottom of my heart, thank you for transitioning to a virtual format for it. And this was outstanding. This is great. It would have been great in person, but this was really great. Thank you everybody for participating. As Dr. Green just mentioned, we have 2 more dates. FDS is not over. We have a whole month of FDS. So we'll see you back on the 21st, the 28th. And just to let everybody know behind the scenes, stuff, there were 2 emails about evaluations. Don't click on the first one. It doesn't work. The second one does work if you got that in your email inbox. So
thank you.
Yeah, there you go. There's probably gonna be an email about the emails, but more to come. Whova still works, so you can find all this good stuff in Whova for 3 months, in fact, and the recorded part of the sessions, including the breakouts, will be available in about 72 hours. So unlike regular FDS, where you only get to go to one workshop, you can watch all the videos of all of them and binge FDS. That is great. So thank you guys for this presentation. It was awesome. It was really great.
Everybody have a lovely afternoon. Bye,
Thanks so much, everyone. Take care.
That's a
Thank
great
you all.
Bye, everyone.
Bye.
Have a great. Wow.